Good afternoon. Welcome to this Brain Injury and Substance Use webinar sponsored by the AdCare Institute of Maine and the BIAA Maine chapter. Today's topic is breaking down the silos, a review of state and community level resources for serving populations with co-occurring brain injury and substance use disorder. The BIAA Maine chapter gratefully acknowledges partial support for this training series from the Administration for Community Living, U.S. Department of Health and Human Services, and the Maine Department of Health and Human Services. Please allow 5 business days to receive your CEU certificate for this webinar. It will be emailed to you along with a copy of the slides directly from AdCare. To ask a question, please type it in the Q&A box of your control panel. At the conclusion of the presentation, I will read as many of these questions as possible to our presenter. If there are any questions we are not able to get through during this webinar, we will respond via email. Our presenter today is Patty King, a NeuroResource facilitator with the BIAA Maine chapter. In this role, she has built a network of resources and connections within the substance use and behavioral health communities to support brain injury-informed care across Maine. She has 20 years of experience as a recreational therapist and is a certified brain injury specialist. Welcome, Patty.
Thank you, Laura. Good afternoon, everybody. So my name is Patty. Like Laura said, I've worked for the BIAA Maine for a little over a year and a half. But as Laura said, I have many years of experience in brain injury. So wanted to share today a little bit of background about brain injury and the overlap with substance use and mental health and behavioral health, and then go into a little bit about the silos and then our pilot work on how we're trying to break down the silos or at least create a bridge. So here are the objectives. Really quickly, just want you guys to be able to walk away being able to have an idea of the prevalence of brain injury as a co-occurring event within the behavioral health system. Be able to identify some of the goals that we're working on in our ACL pilot here in Maine and locate and utilize the helpline number for the BIAA Maine, our website, and also what NRF is and how to access that service. Identifying some best practices. I want you guys to be able to walk away with something you can apply to maybe some individuals you guys are working with. And again, along the same lines, have some compensatory strategies that you can add in alongside the interventions that you're already doing. So why is breaking down silos important? I'm going to share some data that in the upcoming slides, it'll show the overlap of co-occurring brain injury, behavioral health, and substance use. The fact that the diagnostic areas exist simultaneously tells us that we can't treat one without treating the others. If care is completely siloed, we're not treating the individual as a whole. Instead, we're treating segments, and our outcomes are going to be limited because of that. Ask yourself if you were in a car accident and went to the hospital and you had a broken arm and a gaping wound on your leg, and you went into the ER and they casted your arm and sent you on your way and never addressed your leg. Would you feel like you got fully cared for? So if we wouldn't do that to the physical body, why would we do it to these maybe invisible areas of the body like our brain and our mental health? So the intersection of brain injury and substance use disorder, substance misuse, especially in those who have developed a dependency to drugs or alcohol, increases the risk for sustaining a traumatic brain injury. And on the flip side, individuals with traumatic brain injury are also at increased risk for substance use disorder because of multiple risk factors that may include higher rates of chronic pain. Headache is like a chronic severe headache is a typical symptom of brain injury that we see quite frequently. They have a higher risk for pre and post substance misuse. And there may be behavioral changes related to their brain injury that put them at risk for substance use disorder, something like impulse control. There's also ongoing prescribing of opioids. The regulations, as we're probably familiar with, have been adjusted and changed. But when somebody has a brain injury, again, because of that chronic pain, opioids still tend to be prescribed. And then also barriers to treatment. Somebody with a brain injury may not be able to navigate the onboarding to get treatment for their substance use disorder. So really, when we talk about brain injury and substance use disorder, we're talking about a chicken and an egg, which came first, or did they show up together? We really don't know, but we know they happen a lot together. So among patients hospitalized for traumatic brain injury, between a third and 4/5 have a history of substance misuse. Alcohol is the most common. And again, this is a little bit older data, but 70 to 80% of hospitalized patients with traumatic brain injury are discharged with an opioid prescription. So we know the opioid is a pandemic. It's an issue all over. So when you think about individuals leaving a hospital with an opioid prescription, and they may not have the support system to use that correctly or appropriately, how that could easily, that substance could easily be misused. In 5 studies conducted among individuals in substance use treatment, it was estimated that prior traumatic brain injury occurrence ranged from 38 to 63%. So potentially over half of individuals in substance use treatment were found to have a brain injury. And this is a lot of statistics. Bear with me. I'm going to tie it all together. But if you have any questions, feel free to put them in the Q&A chat box. If a person misused alcohol or other drugs before the brain injury, they're 10 times more likely to resume substance misuse after their brain injury. And individuals with traumatic brain injury are 11 times more likely to die of an accidental poisoning or overdose. Again, when we talk about memory, impulse control, and challenges such as that, it makes sense, but it's still a staggering number. The suicide risk is also 2 to 4 times greater in individuals with TBI when substance use and/or mental health illness co-occurs. Even without the co-occurrence of substance use disorder or a mental illness, there was a Danish study that showed TBI itself increased suicide risk by 3 times in the first 6 months from the injury, and it remained elevated for the length of the study, which was 11 years. So this chart I borrowed from the Brain Injury Association of Virginia. And what I like about it is that it shows the overlapping symptoms from concussion, which we refer to as a mild traumatic brain injury, to it overlaps with anxiety and depression and substance abuse. And you can see that mild traumatic brain injury and substance abuse have all the same symptoms that are listed on here. So it becomes very difficult for professionals even to figure out which is the root cause. Is it concussion? Is it substance use? Is it both? What's causing these symptoms? And in order to appropriately treat those symptoms, knowing the root cause can be extremely helpful. This is a Venn diagram showing some of the overlap of traumatic brain injury with various underserved populations. So with the title like TBI and it says 12%, that's the rate that TBI occurs in the general population. So mental health, 19%. Where you see the overlap between TBI and mental health, and it says 33%, that's the number of individuals with a traumatic brain injury who may have mental health challenges as well. So when we look at the statistics, we can see that it's 33% overlap with mental health, a 48% overlap with substance use disorder. The number I don't have is when substance use disorder, mental health, and traumatic brain injury all meet together. And then populations we're not really going in depth, but I wanted to recognize our survivors of intimate partner violence can have a 30 to 74% chance of having a traumatic brain injury. Veteran populations, the statistics there are a little hard to pinpoint, but one I was able to find was 19% of those serving in Iraq and Afghanistan. And then the incarcerated population has an extremely high rate of traumatic brain injury. In adults, it ranges from 41 to 82%. In juveniles, it's even higher. So when you get an individual that has that background or a mix of these backgrounds, you can start to see how it could be exponentially increase the risk of them having a traumatic brain injury or suffering a traumatic brain injury. These are some statistics that we got from one of our third-party surveys. This one was back in 2016, but I think it still holds pretty true. So in this survey, they asked here in Maine, how many individuals have an additional diagnosis to their brain injury, and 80% of the 129 surveyed had an additional diagnosis. And then of that 80%, they broke down how many, what type of diagnosis that was. And in this case, 53% had mental health diagnoses and 9% substance abuse. And then the other graph shows, have any of the following stopped you from receiving services? 16% replied that they didn't know they had a brain injury. So I want to carry that one forward when we start talking about the importance of screening for brain injury. Could not find information about the services, 24%. No one to advocate for me, 28%. Service providers' lack of knowledge about brain injury, 28%. And other people's lack of knowledge about brain injury, 42%. Why I picked those out is they really are the basis of why NeuroResource facilitation is important, and the work that we're doing is kind of guided by these findings. This is from a more recent survey done by Kone Consulting for the Brain Injury Association Maine chapter, and they identified 42% have previously or are currently receiving mental health services. So this was done last year or the year before, excuse me, it'll be in the resources, but the piece I wanted to really pinpoint here is the individual who is quoted saying, "Depression is the biggest struggle I've dealt with. I'm in counseling, but my counselor doesn't understand the brain chemistry of a stroke." So it's not to say that that individual isn't a good fit with the counselor, but maybe we could just let that counselor know that we're here, and if they want education or support or ideas, they could reach out to us here at BIAA Maine so we could help them help that individual. And I actually hear that a lot, that individuals really want some sort of service, whether it's counseling or primary care physician, but they feel like they don't understand the whole picture of who they are because they don't understand the brain injury, or they feel they don't understand the brain injury. So again, types of mental health services that brain injury survivors in Maine are accessing. So the dark blue line is those currently using those services, and the gray line is the ones that they wish they could use, but there's some barrier to them not being able to access that service. So some subjective observations I've made working in this field is that accessing services can be difficult for individuals with brain injuries due to navigating the onboarding process. So some examples of that might be transportation. Many can't drive. They may not have access to a support system that can drive them, so they'll rely on public transportation to get to appointments and return rides. In order to set up that public transportation or find what bus gets them to the right route, it takes skills like planning, memory, organization, initiation, and follow through. All of these areas are executive functioning skills that can be impacted by a brain injury. Phone trees are also a point of frustration for many survivors that I've encountered. In order to get through a phone tree, it takes our working memory to hold on to those options long enough to dial the correct one. It also requires them to follow directions, which sometimes can be challenging, again, because of memory and planning. I get lost in a phone tree some days. I find myself jotting down what I think might be the best answer so I can continue to listen to the other options and go back. Someone with a brain injury might not be able to incorporate that strategy on their own. So encouraging places to have an option that, somebody could talk to a live person or not have a phone tree at all if possible. I do want to note the crisis number has a phone tree. And I note this because I did have a survivor end up calling me in crisis because he wanted to call crisis, but he couldn't get through the phone tree. His brain injury was too much of a barrier. I was able to assist him in that moment. I was available to answer the phone, which I'm thankful for. I was able to call crisis with his consent and give them his number for them to call him directly. But that's something to note when you're working with individuals, is making sure they can access the resources we give them. Here's a graph that shows the receipt of mental health services by consumers. So again, how many are using services? So about 42.2% of brain injury survivors are currently using a mental health service at the time of the survey. And that was out of 223 respondents. Maine has over 10,000 brain injury survivors. So again, it's kind of a small pool of respondents, but it's important data to collect. Again, some observations from my work. Several calls are received monthly by the staff here at BIAA Maine from individuals looking for mental health services with providers who have some sort of brain injury experience or knowledge. And we currently only have 3 individuals listed in our resource directory that claim to have a brain injury background that are not currently part of what we call a 102 clinic, which is an outpatient Maine Care funded neurorehabilitation program. To be successful in mental health services, individuals with brain injuries often need additional accommodations and supports to follow through and carry over with the tasks that they're asked to do to improve their mental health. Make sure I didn't skip any. Okay. Maine, our ACL grant, which is the Administration of Community Living, is a federal act that provides grants to states. These grants help states increase access to services and supports for individuals with traumatic brain injury throughout the lifetime. And the goal of the grant program is to help states expand and improve state and local capability so that individuals with traumatic brain injury and their families have better access to comprehensive and coordinated services. So this is the grant that my current work in the pilot is being funded under, along with coordination with the Office of Aging and Disability Services. So when Maine applied for the grant, our overall goal was to build and enhance and expand state infrastructure for a system of services and supports for all people with brain injuries across the lifespan, their family members, and their support networks. When we applied, when we received the grant requires us to have 4 areas that all states that receive the grant work on. Those areas include screening, training the workforce, providing information to families and referrals to appropriate service providers, and facilitating access to needed service through resource facilitation. Outside of those 4, Maine also was able to identify their own goals that they'd like to work on beyond that. I listed them all out here, but I'm really just going to talk about the 2 that this talk focuses on. So goal number 3 was objective number 3 was to increase the capacity for statewide resource facilitation to help persons with brain injury, families and caregivers to navigate the post-acute chronic phase of recovery. And objective 8, to enhance the capability of community-based substance use disorder and behavioral health treatment providers to serve persons with co-occurring ABI, which is acquired brain injury, and the substance use behavioral health systems, and to raise awareness of the link between overdose and anoxic hypoxic brain injury. Laura, were there any pressing questions?
No, there weren't.
Okay,
thanks.
Perfect. So as we talk about the silos, how do we break down the silos of care for individuals with brain injuries? How do we take all this information, all these statistics that we just discussed, and apply it to go forward? So first we have to identify what the silo effect is. So a silo effect refers to a lack of information flowing between groups or parts of an organization. On a farm, silos prevent different grains from mixing, but in an organization, the silo effect limits the interactions between members of different branches of the company, which can lead to reduced productivity. Our current healthcare system is one of silos. When you think of just payers, you've got private insurers, Medicare, Medicaid, hospitals, uninsured individuals, all are in their own silo. And then when you think about treatment types, you've got hospitals, nursing homes, home health, hospice, all of these groups. And then you've got regulators and state and federal levels, all working independently, but yet we're connected because we're all working with the individual. And it really leads often to a haphazardly managed system. So what are the benefits of breaking down silos? Removing silos fosters innovation and increases productivity, and also increases collaboration. If a coordinator of a discharge from a hospital assists residents in transferring to and from the hospital, this may create a bridge between the organization that fosters improved care and reduces hospital readmissions. Sometimes a lot of hospitals now are including a care manager or some similar role that will call and check up on somebody after an ER admission or after multiple hospital visits and help coordinate their care. And I can say, as a family member of an individual, that was a lifeline for us when we were working on my brother's ALS diagnosis and process. Just having that one person that could direct us and guide us. So that's really part of what NRF is, our goal is to provide that support while people are transitioning from one to the other. Providing bridges between services gives individuals a sense of security, holistic care, and compassion. It also reduces confusion and redundancy. A lot of those words are so important to survivors of brain injury. Having a sense of security. Many of them don't know who they are anymore right now, especially if they're new to their injury. Often they'll feel very, very different. So it's important that we give them that sense of security. We've got you. We're gonna get you to where you need to go, and we're gonna try our best to get you hooked up to the resources you need. And it also, the reducing confusion. The world can be very, very confusing if your brain is not making the proper connections. So if we can reduce that confusion and help them keep things organized, that can be a major step for them. So our pilot programs. So again, our pilot programs are funded through the ACL in conjunction with the Office of Aging and Disability Services. One of the primary goals of the pilot is to have 3 locations where we're running this pilot program for brain injury screening and follow-up. Right now, we have 2 active in a planning phase where we're meeting regularly. Tri-County Mental Health Services based out of Lewiston, and Kennebec Behavioral Health based out of the Augusta area. Both have a much further reach than that. But those are their main hubs. And we'd like to start rolling out some of the screening, hopefully by January of 2024. And then we're also in preliminary discussions with a site based in Aroostook County so that we can really address some of the rural populations and see how NRF can assist those in behavioral health or substance use treatment. Anticipated outcomes are increased training for behavioral health professionals, screening for potential brain injury, and linking to the NRF or just our general BIAA Maine services and supports. So how we designed the pilot after some initial discussions is we really leaned on the organization NASHA, the National Association for State Head Injury Administrators, and took their system impact model and applied it to our pilot so that we had a structure to build this on. So once we had that structure, we then created what we referred to as a care map for how we would go through this pilot. So first off, we were going to talk about training. So some of the training pieces that we've identified that we can provide is something called Brain Injury Fundamentals, which is, I'll talk a little bit more in depth about each of these on the next slide. The OBIS training, which is training for the screening tool that we use, and designing any specific training based on needs or interests identified by the pilot site. And then the next stage would be screening. So again, using this OBIS tool, which again, I'll talk about in a minute. If they screen positive or negative, then we kind of have our tree from there. So if they screen positive, we would offer a referral to BIAA Maine, NRF services or resources. If we identify functional symptoms, we then have at one of our pilot sites been able to link with one of our resource rehab programs. And they have agreed to provide some neuropsych screens and recommendations. Neuropsych is kind of our golden ticket of information for a lot of our individuals. It's also a required step for accessing the brain injury waiver funds. So this is a huge ability for us to link to this and reduce wait times. Often people for a full neuropsych screen are waiting years to get in. We're able through this coordination to get them a screen within a few weeks of referral. So definitely a huge benefit. After the neuropsych sends out the recommendations, if that individual is okay with sharing them with the NRF can then help them explore those recommendations. Say the neuropsych identified occupational therapy. So then I could work with them and say, okay, would you like occupational therapy? This is what occupational therapy does and provides, and then help them find providers in their area. Ideally, we'd like to find people with the brain injury background that could serve them, or one of those 102 clinics. But if those aren't accessible or doesn't meet that person's need, we can definitely look at other locations to get that service. The NRF, this kind of also happens at the same time. Once they've decided they might want NRF services, then we would assess them and set goals for what they want for support and resources. So a lot of the initial meeting I do with people is, what would you like to be able to access? What are your current barriers to accessing that? So, one individual, he wants to have a home where he feels safe and secure. Okay, well, that sounds to me like we want to explore the brain injury waiver so you can get some in-home care and get some support and somebody checking in on you because you don't currently have a lot of natural support, so family or friends in the area. If the person screens positive and they don't really want NRF services or don't have anything they really need to work on right now, then we can just provide some, links to, or have a little discussion about what brain injury is, what effects it might have. And we can still provide accommodations. We're here for the professionals as well as the individuals, as well as the families. So we are happy to talk about and brainstorm different ideas. When we talk about brain injury, it's not always about having the answer. It's about having a whole bag of tools that one of those tools might be the answer. So it's a lot of trial and error often to find the right fit. But the goal is that we as professionals in brain injury have that toolbox that we can share ideas. And then also if they screen positive, but they don't really want NRF services, we can also, the providers can check in and rescreen if they report a change or a new potential injury. And if they screen negative, no further action is needed. But again, they can rescreen if a significant change is noted, or if the person says, hey, I was in a fender bender yesterday and bumped my head off the dashboard, but I didn't really want to go to the doctor's. Most likely that's going to come up as a positive screen. Along with the positive screening, and we'll talk about OBIS a little bit more, it does come with, it's just a screen, it's not a diagnostic tool. So if they don't already have a diagnosis for that brain injury, part of the recommendation is that they talk to their primary care provider about getting that diagnosed and any follow-up care. So again, some of the things I mentioned under training, going back, is that Brain Injury Fundamentals. It's a training and certificate program through BIA that's designed to address the unique needs and challenges of those who care for or encounter individuals with brain injury. If individuals go through that and they're like, ooh, I really liked what I learned, I can see how this is helpful, they can also step up and pursue a CBIS, which is Certified Brain Injury Specialist, which is a full certificate program that's nationally recognized. And it's for professionals working in brain injury services. And it has annual CEUs and there's a renewal process. So it really keeps you striving for best practices in brain injury. And then our OBIS screening. So our training for that is a 1-hour web-based training for the providers that'll be using the screening tool. And that training is provided along with our contract to use OBIS. So NASHA supports that. So the OBIS was subscription to it was purchased by the Office of Aging and Disability Services. And right now it's going to be used in our pilot site, but the hope is that if everything goes well with the pilot sites, it could be accessible to a multitude of programs, or even accessible across the state eventually. It's based on the Ohio State University Traumatic Brain Injury Identification Method, also called the OSU for short, which is a standardized procedure that's been around for years. It's a valid, tested screening tool. And it has not just a screening for brain injury, but also a symptom screener after that as well. Currently, this is a tool that we'll be using. Again, it screens for brain injury and also collects some demographic data and provides resources that will be vital to the individual for any follow-up care. So if they take it and they screen positive, it will kick out an email to them immediately with, you screen positive, please see your PCP if you don't know that, that you have a brain injury. And it has attachments of things like the NRF information, the Brain Injury Association website. Also our pilot sites are including information there. ODES is included information there, Disability Rights Maine. So they'll have access to several links that can get them some more information immediately. And then if they take the symptom questionnaire, let's say the symptoms pop up that they're having trouble with memory. After that, they'll get a link to a page from MindSource, and that is in my resources. And that has best practices and tools for each of these symptom areas. So they'll get a page of things that they can do to help support their memory, like using a journal, setting alarms on their phone, getting good night's sleep, having good sleep hygiene, and so forth. And this here is a picture of the flyer that the provider site will have, so they can quickly get to it using the QR code, or they'll have a link and a password on there. It also explains a little bit more about the OBIS itself. So the next stage of that system impact model is intervention. So some of the ways that we're providing intervention is the NeuroResource facilitation. We also have created these rack cards, and this is an image of it. It's a 3x5 card, so it can easily be put in a back pocket or a wallet. And they're for the pilot sites or anybody to hand out to help increase the awareness of potential overdose being a cause of a potential brain injury. So it has some of that information. And then on the back side, our pilot sites have put some of their information to help individuals link the two together. So if they already are established with our pilot site for care and have built that rapport, that hopefully that will help them transfer over to feeling comfortable reaching out to the Brain Injury Association of Maine, Maine chapter. So that's one intervention that we've been able to put out. We've made it just a 3x5 card because we also want to make sure it's accessible for populations like those who are unhoused and things like that. So it's easy for them to kind of carry around and keep on them. We talked about the neuropsychology screen, which was an intervention, assisting people to apply for waivers such as the Section 18, which is the brain injury waiver, and the Section 20 waiver, which is other related conditions. And NRF, can basically walk step by step through that process with individuals. And then providing education like we're doing today, talking about it, helping people identify their support system. A lot of people don't understand what a natural support might be. They don't understand that their neighbor, Betty, who, they talk to every day when they go get the mail, is actually kind of a support system for them. That's somebody that knows every day if they're doing okay. So how can we utilize that relationship with Betty to make you feel, secure or meet your needs? And then also linking to long-term support. So again, whenever possible, building those natural supports for long-term carryover. So NeuroResource facilitation, I've discussed a lot of this, so I'm going to kind of skim through, but It's known as NeuroResource facilitation or resource facilitation. I refer to myself as a walking, talking phone book for brain injury. It's nationally recognized and it's an evidence-based service. According NASH's definition is that it maximizes home, community, or vocational outcomes through the provision of brain injury specific education and resources. There's some studies out there from the Midwest, I think it was, that identified related to vocational. They went from, with prior to NeuroResource facilitation use, they had an 11% return to work. After the inclusion of NeuroResource facilitation, they had, it was above a 50% increase in people being able to return to work. So that was one study that kind of really vetted NeuroResource facilitation. Each state offers NRF has a unique design, but with similar goals and outcomes, which is really nice because it allows us to tailor it to what our state needs. What do the individuals here living in Maine need? Those living in the county who may be 3 hours away from any particular services, or don't have great internet service and can't use telehealth. So we can really tweak our approaches that way. We're nonprofit, we're grant and contract funded. So what's really nice about that is it means we can work alongside any other treating organization or group. So if somebody has case management through a mental health provider, we can support the individual and the case manager because we're not billing their insurance. We're kind of free to help them without worrying about overlapping services. And our ultimate goal is to bridge the gap between the different stages of recovery and different service areas. So our purpose, I talked about a little bit in the beginning, about why we started NeuroResource facilitation, those indicators for it here in Maine. And this is another graph showing information from that same Kone survey. So many individuals with brain injury in Maine do not qualify for case management, social services, or other professionals that assist in supporting them in their journey. And if they do qualify, there often are extensive wait times for their service, or the service they were able to get doesn't fully meet their needs. So part of the goal for NRF in Maine is to fill in the need gap to keep people safe, getting the services they need and qualify for while waiting for more formal case management, or support current professionals navigating the brain injury specific nuances to create some improved outcomes. So really you can kind of boil all that down to NRFs are a form of subject experts for brain injury here in Maine. So how NRF works, again, it has these 5 stages. When we first meet with somebody, they can access our services by reaching out to the helpline. There's also an application for NeuroResource facilitation right on our website that they could download and send in. After they're approved for NRF services, the NRF would reach out and contact them. Again, I kind of already talked about how we do the assessment, figuring out what their goals are, figuring out a plan, and really just starting to break things down. People can get very overwhelmed and overstimulated who have had a brain injury. So part of what we do is just break this all down into smaller chunks while trying to keep the big picture intact and get them to work through that. We don't have any service time limit. We have people on our caseload from a couple of weeks to I've had a few for over a year. It really depends on that individual. There's no cost to our services because it's funded through the contract with ODES and grants. And again, it can overlap with most any other services. So a couple little short case studies. Again, I'm not going to read through all of this, but one instance is an individual working with them. They had a history of brain injury, some mental health diagnoses, and had in the past had some substance use disorder struggles and was in recovery. NRF, so myself was added to her team after she already had established a case manager in counseling through her mental health services. So really my role became supporting those professionals and also picking up pieces that didn't quite fit into their wheelhouse. So I can assist with the brain injury waiver application so the case manager doesn't have to carve out that time from what they're doing. I can assist the case manager in looking for housing, coming up with ideas and options, looking at employment for her. Finances were something that was important to her. And part of it too is like her case manager is working with her on her SSDI, but part of what I do is also just support her in sticking with the process because it's long and frustrating. So letting her vent to me as she gets frustrated and saying, it's okay. This sounds actually the way it kind of goes. It's a long and frustrating process. I get that. Let's keep chugging, and just giving them that support as well. And I could also assist with referring them to outpatient rehab specific to her brain injury and support groups. And then an individual that was able to discharge and come off our services was a gentleman who was a stroke survivor in a nursing home. His wife was his champion. That was his primary support system. And some of the initial stuff I did was just listening to his wife talk to me about her concerns. She had some frustrations about communication with the nursing facility. I kind of lucked out in that I had experience working in a nursing home, so I could really kind of help her figure out how to ask the questions she needed to ask to get the answers she needed. So I was able to kind of use an informed approach of, okay, this is how the staff's looking at it. So this is maybe the question we need to ask, or this is the request we need to make in this format. And that really helped smooth things there. And then she also had a lot of family dynamics going on related to her husband and their power of attorney. So making sure that they were linked to legal support and financial support, applying them for the waiver, helping them understand the Section 19 that was processed through the nursing facility for his discharge. And eventually he was able to go home, had neuro rehab still as an outpatient, transportation, and she was able to send me a wonderful picture of him in his recliner with his remote control beaming ear to ear because he was home, and it had been well over a year. So some barriers and opportunities that we see here, and I'd love any feedback anybody has. So again, if you want to make comments or statements, feel free to put those in the Q&A as well. But some barriers we have is limited resources. There's only a certain number of residential brain injury beds in the state of Maine, and they're only accessible through Maine Care or private pay insurances at this time. The rehabilitation locations, again, if somebody is living in the middle of Piscataquis County or northern Penobscot County, they may be quite a ways away from a neuro rehab clinic. The waiver, the Section 18 waiver, does have limited funding, so there is an extensive wait list. Coverage for long-term services, if somebody does not have Maine Care, that can be a barrier or a challenge, is to get insurance coverage. And staffing, currently we have 3 part-time NRFs here in Maine and 1 information and resource, so the person that answers the helpline and gives some of that first line information. Other barriers and opportunities are education about brain injury and best practices to those who are serving high-risk populations. So again, this is an opportunity. If anybody's willing to talk about brain injury, I'm here to talk about it. And we just really want to get more awareness built around that. So what are some next steps? And again, if there's thoughts, this is an open discussion in the Q&A and chat if you guys have information to share. So speaking of information, information sharing. So that could be a next step, providing two-way communication and cross-training between providers. So part of our pilot discussion has been, we have individuals from a neuro rehab clinic on our pilot program work group. So can they provide information to the pilot site, and can the pilot site provide information to them to make a more cohesive care system? Widespread access to screening and training. So again, as we're piloting this OBIS, is it possible to use it across the state and provide the training? Systems and policies are the last 2 steps on the system impact model that we're following. So as the pilot program progresses, figuring out what's transferable to other organizations that serve high-risk individuals. So can we take what we learned in the pilot program with substance use and transfer it to incarcerated populations or veteran populations or unhoused populations? You know, what's going to transfer, what worked, what didn't work. And then the last step is making policies for those locations and helping them build policies that will help them create a sustainable and systematic adjustments to take into account the risk of acquired brain injury. So the goal is always collaboration in a person-first model. In other words, we need to work together and always keep the individual served as our focus. The individual communicates their needs and goals, and the team works together to support the individual in moving forward towards achievement. This is different from the silo model where each discipline works with the individual and then floats them to the next step. A lot of times they'll get discharged and literally follow up with this person, and then they've got to go through all of that onboarding with the next group. Whereas something such as a warm handoff, where that person calls and initiates the onboarding for them, could be potentially the difference in that person falling into a black hole of no care and actually making it to that next step. By creating an inter-organization network, we can give warm handoffs, break out the workload, and support the individual through their transitions, creating an environment where outcomes improve and the individual can thrive and feel supported throughout. Were there any, I have some best practices here. Is there anything pressing, Laura?
I do have a couple of questions related to what you just talked about.
Sure.
I'll start at the top here. Are there any particular qualifications needed by providers in order to sign up for the screening tool training?
So right now it's used just through our pilot, but once we establish that, definitely we would love to see people do the fundamentals, which is an 8-hour course. I think I'm just kind of spitballing here what my recommendations would be. But at least just the OBIS screening training, which is just a 1 hour, how to use the tool, interviewing techniques. The OBIS is actually designed that it can be self-administered. So there really isn't any training that has to be done, but I think a best practice would be to kind of familiarize yourself with the tool beforehand and familiarize yourself a little bit with brain injury.
The next one, you kind of alluded to already, but how accessible is the brain injury waiver program through ODES? I frequently hear that there is insufficient funding to bring new individuals into the waiver program.
Yeah, so it's set up in a priority system. There's 2 levels. So priority 1 are individuals who are in facilities of 8 beds or more. And they really kind of get access to the funding because the goal of the waiver is to get individuals out of institutional care and into the community. So for those who aren't in those type of situations, and I'm probably missing a lot of details here, but those who aren't kind of in that category that are in the community and doing well will be in that priority 2. Then the wait list can be extensive, you know, well over a year, sometimes more.
Another one is, could training be open to assist my team of peer leaders, like house managers and wellness drivers?
Absolutely. Reach out and we're happy to do webinars, in person, virtual, whatever fits for you. We're happy to spread the word. Going back to the waiver real quick too, I do want to mention that there is always talk of trying to get more funding for that waiver. It's an ongoing living, breathing thing. So I always encourage people to sign up for the waiver if they think there's a chance they need those services. Get on the wait list, because if you're not on the wait list, you're not going to get those services at all. So I did want to kind of add that as well.
The next one is, what are the requirements for proving brain injury to receive residential services?
So they would need either a diagnosis from a primary care, from a neurologist, a neuropsychologist, or a physiatrist are all areas where they could get that diagnosis. And then from there, in order to get the funding for a residential home, they would have to go through the waiver for that main care. So they would have to have either the neuropsych or a physiatry note. So if you have somebody that's kind of interested in that, my best advice would be to reach out to us and have us help you kind of get those pieces in place.
And another one is, what if someone cannot go through the neuropsych eval if they don't have the patience and ability to pay attention long?
So neuropsychs are well versed in brain injury, particularly ones that work at like a 102 clinic, a neuro rehab clinic, because they also do counseling and follow-up care. So not to say others don't, I'm just not as familiar with them. They're well aware. Sometimes they can break up those sessions. The screening program I kind of talked about that we're trialing with the pilot is about a little under a 2-hour process, whereas a full neuropsych screen can be a full day of testing. So, I really would encourage them to break it down into smaller chunks. And that would most likely be possible for some of it. For some of the testing, they might have to be able to, I think the screening testing is, I think Dr. Murtaugh said it was 30 minutes. But if they don't finish it, that kind of tells us something about their brain injury as well. So I would say it's worth talking to them and trying to find accommodations.
Okay, that's all I have for now, but I'll follow up with some more later. Thanks.
Yeah. So some best practices that you can hopefully kind of take with you is we've already talked about some of it. So we know it can be challenging to differentiate whether behaviors and symptoms that include things like failure to complete a task or being disinterested, what we would consider inappropriate social behavior or ineffective social behavior, lack of self-awareness and tangential speech can be a result of traumatic brain injury, or they could be behaviors related to a different diagnosis or just that person's personality. I'm sure we've all met people who are close talkers or people you can never get a word in edgewise. Sometimes that's just a person's personality. Sometimes it's a symptom of something bigger. So how do we figure that out? How do we address it? So you guys have already taken the first step. You're here at this webinar educating yourself about brain injuries. The screening tool we talked about. So you also, kind of going back to that question that was asked, you don't have to use the OBIS or the OSU as a screening tool. There are several free screening tools out there online. The OSU itself in a paper format is available online, as well as a screening tool called HELPS, HELPS. And there's several others out there. Most of them focus on traumatic brain injury. So I would just be aware of that, especially if you're working with substance use populations where an anoxic brain injury, where there's a lack of oxygen to the brain for a period of time, or other acquired brain injuries are common. I would ask about those just as a kind of a separate subset. And if they have any history of those type of events where they've lost the ability to breathe for a period of time, or had a seizure that they can't explain, or a stroke or TIA, those would all be positive events for further follow-up for brain injury. And then identifying and accommodating neurobehavioral deficits. So if somebody is having challenges, how can we accommodate that? How can we identify that? I was talking the other day about, individuals who may be deemed resistive to care or refusing. Well, are they really resistive or refusing, or are they just not able to participate because of other barriers? And that kind of makes us have to be detectives, which is kind of a little bit of a fun part of the job for me, is being a detective and trying to figure out what that root cause is. Do we always get it right? No, but we try. Also addressing comorbid interactions. So again, if somebody has other mental health diagnoses or substance use or insomnia, we want to address those as well as the brain injury. Referring them to community supports. I've talked about a lot of those today. Creating formal and informal supports needed during and after treatment completion. So again, making sure we're trying to do those warm handoffs if it's appropriate or okay. And referring them to community supports to help bridge that gap, helping them build natural support systems. And then, for those of you that are substance use providers, recovery coaches, peer coaches, talk about the substance use dangers related to brain injury. Once somebody's had a brain injury, most drugs and alcohol intoxicants affect them differently than they did before injury. So if they're considering returning to using a substance, even caffeine, we really want them to know that it could affect them differently. So to make sure they're taking steps to make sure they're safe. I know, a lot of the groups I'm a part of, I've learned about some harm reduction strategies, and I've learned so much. But, talking about harm reduction and adding in that brain injury component to it, how can we make this as safe as possible? And also, always abstaining from substances is always ideal, but for some, that's not an option. Or it's not an option while they're waiting for recovery support. If possible, when you're working with somebody with a brain injury, you may need to create a quieter environment than normal with minimal distractions from your meetings. A normal functioning brain can filter out a lot of things. A fatigued brain that has potentially a brain injury can't filter out hardly anything. So the more we can adjust the environment, the better focus the individual can have, and often the less behaviors somebody has. And I'm going to say the word behavior, but I don't want you to think negative. Behaviors is just a form of communication. And that communication in this instance that we're trying to reduce is that they're overstimulated or fatigued. When we talk about fatigue, also, frequent rest breaks. If you have an hour session, if you can give them 5 to 10 minutes in the middle to just reset, that can be extremely beneficial in them being able to absorb the information in the second half. Presenting information in smaller chunks. When somebody's new to their brain injury, sometimes their memory is so poor that we actually will break out how to brush your teeth into 10 or more steps that they have to check off on a sheet. You don't have to go that far with everybody, but really think about, how can I break this down? How can I make this smaller steps that are achievable to help reduce frustration and overstimulation? Other common strategies, small groups, journaling, video and audio recording can be very helpful. Again, with all the proper consents and all of that. And role play can be both fun and very helpful, especially if you're struggling with somebody with very concrete thinking. I've seen role play do some really great things in their progression to get to a more flexible mind state. And then always create a collaborative care team approach. Don't be afraid to reach out to others and pull them in. And I know we're up against time, so brain injury resources and supports through us. There's tons. Reach out. I also have my contact information, and we have our helpline number. All of these supports are accessible through that helpline number. That is the gateway to pretty much everything. And then this is just some information about Section 18 about that brain injury waiver. So if you're interested in that, check your emails for my slides and you can read more about it or reach out directly. And then I just attached my resource pages as well. Thank you, everybody, for coming. If there's any quick questions or anything I can follow up on.
Yeah, one was, are there suspicions that the quantity of Maine's population with brain injuries may actually be largely underreported?
Yes. Brain injury as a whole nationally is underreported. And that's part of why the screening tool is going to be really interesting, is the data that it will produce for us on identifying brain injuries that may have been not found or identified. Many people won't go, they may, especially, think intimate partner violence, where somebody may have had blunt force trauma. They may not be able to seek medical care for that or a diagnosis for that because of the confines of that situation. Somebody who overdosed and had an anoxic injury and Narcan was administered, but they didn't seek medical care, maybe because of fear of their illegal activity, or somebody who was assaulted outside of a bar may not seek medical care because of the stigma or the fear of legal activity.
Yeah, I have a couple more questions, Patty, but can I just send them to you and you can get back to the people via email? Would that be okay?
Absolutely. Absolutely.
Okay, great. Yeah, well, thank you so much for your great presentation. And thanks
Okay.
again, everyone, for joining us today. Have a good afternoon.
Thank you all for coming.
Thanks.